Dr. Jeremy, aka Dr. Dinkin, Dr. Dinkelberg, as he's sometimes referred to as. Jared, this is the first, we'll say, expert appearance that we've ever had on the Modern Meathead
Wow.
Experience. Yeah, my first question is, how does it feel? I mean, 50 episodes in, you're the first expert. How does it feel?
That I am very honored. I'm just
Okay.
floored right now.
Yeah, well, I'm honored to have you here. You have a new tattoo, which is quite exciting. So, just for those who are listening, Jeremy has a new tattoo. It's sick. And yeah, Jeremy, so you're a chiropractor by trade, technically speaking, although there are some nuances around what that actually means that we're definitely going to talk about. But for those who are sort of unfamiliar with the specifics of Cairo and like what Cairo actually is, can you give us a kind of like 30,000 foot view on chiropractic and sort of, what they would maybe teach you in school as sort of the first principles of chiropractic care?
Yeah, it's a great one. So in school, they teach you how to do traditional chiropractic. So basically, that your spine's out of alignment. You got to readjust the spine, get you back in neutral or whatever they call it, homeostasis.
Sure.
And that's kind of why I never really jammed with that. I didn't typically agree. I worked with a chiro prior to school, and I almost didn't even go to chiro school because of the old school traditional thought process behind everything. But I gave myself a shot. I knew that there was a way to do it a different way. So chiropractic in and of itself is essentially that. You're pushing bones, you're realigning the spine. There's a misalignment, you push it back, right? And so I was never really on board with that. And so when I was in school, I had to do my own homework and shadowing, continuing ed courses. A lot of the stuff that I took as like valuable information was away from school, unfortunately. And so you go through. I was in fifth term, almost halfway through, and I didn't know where I was going to go with this. I was refusing to do the traditional model. And typically with that, people see a lot of car accident patients. That was not my crowd. I was more the football player, sports background, strength training, and so I knew that I wanted to get into the sports world a little bit more. And so I started to shadow those type of clinicians and PTs, sports PTs, athletic trainers, anyone in that field. I just started to shadow and try to pick up as much as I could. There was a Cairo in Santa Monica, California, who ended up being kind of like a mentor to me. He worked with the Olympics. So trying to surround myself with those people and just to see what was more out of the profession. Like, how much more can we do? It's not just, for me, it was like a simple adjustment and then like maybe some stim and a stretch was just not enough, especially for people who are trying to push it and maximize performance and stay in the game longer. That was more my crowd. And so chiropractic is kind of split now into two, almost like Democrat, Republican. You got like the old school, um, you got the old school traditional chiros that still practice that way. There's students that still, like that model and want to do that. And then there's the newer age chiros that kind of blend everything with like PT, strength training, pelvic floor, kind of blending all of those worlds into one. And so that's kind of where I categorize myself.
So that's interesting. So Cairo fundamentally, would you say, is a model that is based around the spine and a focus on the spine? Would that be an accurate representation?
100%. And that's why, people typically they come in and they sometimes ask me like, "A, what is your title?" Like based on your Instagram, like we don't even know. And then can you do you even help like knee pain problems? And
Hmm.
it's yeah, the common misconception is that we only treat the spine and we're only going to do adjustments and then that's it.
Right. So what I've learned from you, in just in knowing you for, 4 years at this point, and in just some of the things you mentioned briefly, it seems like the common model for, we'll say, the traditional Cairo is one wherein a patient comes in with some kind of problem, and there's kind of this cookie cutter template which says, hey, you're going to come into my office, maybe 5, 10 minutes, maybe even less, right? Go through the insurance. I'm going to snap, crackle, pop you, and then you're going to be on your way. Is that kind of still where the traditional realm falls?
100%. And again, it's very, temporary, right? It might feel good in the moment. You might feel good for 20 minutes. But typically, that's not solving the issue. And
Yeah.
so it
So,
feels good, but not long term.
Right. So I've heard many similar stories that sort of align with that experience where someone will have chronic pain, they come in, they feel better, they leave, and it creates this sort of positive feedback loop, this inherently negative positive feedback loop where, you feel better, you get a massage or something similar, and you sort of need to come back. And so would you say that's maybe part of the reason why Cairo gets a bad rap? Because I do think that there is more and more over time, and obviously I'm not speaking from a clinical perspective here, but I have definitely seen a little bit of a change in the overall space, sort of away from cookie cutter templates that are more traditional. Would you say that the sort of bad rap around Cairo is then justified, or do you think that there are many Cairos who are sort of, as we'll talk about, doing what you're doing in a little bit more of an integrated way? Do you sort of see that spectrum changing over time?
I do, and I do think that there's, tons of merit behind why people think chiropractors are, quacks and all that, because it is a very, very small world that I'm living in. And I realize that I'm living in my bubble. And so in our bubble, like this is our norm. But when you hear patients like tell their story, it's every day. Every day I see a patient that's been to a different office, whether it's PT, chiro, um, they get the traditional stuff, which is what they're taught in school, and then they go out into the work world, and they get a mentor that's also doing the traditional model, and so that's all they know. And
Mm,
so, if you follow me on Instagram, I can literally write word for word like what you'll expect at those typical offices. They'll X-ray you, they'll tell you what's wrong with you, they'll show you how they correct it, and then they sign you up to this long, treatment plan, which is only like it's the treatment plan itself is only adjustments and stim,
mm,
but they'll sign you up for 50 sessions in a package, then retest the re-show you the X-ray and see all the minor improvements that you have, and then get you onto another one, right? And so chiropractors can definitely come off as sleazy, which I 100% understand and see, because unfortunately I did work at a place like that before school as an assistant, and I got to see kind of the dark side, which again I didn't agree with and didn't want to do. So it's
mhm.
still very rampant. Our model is very unique and kind of like in a smaller bubble, but through Instagram, thankfully, and like social media, it's starting to gain a little bit more traction. I've gotten so many DMs over the years, like, can you teach me this model? Like, what do you guys do? How do you fill up an hour slot? Like, those are not taught in school. And so when you graduate Chiro school, you're like, all right, now what? You end up getting a job, like I said, with a traditional place because that's the only place that's hiring, and then you fall into that model.
Hmm. Yeah, so you mentioned a couple times there that you had this sort of model in this framework. And for those that don't know, this will be in the show notes. You follow the RSM model, resilience, strength, movement model. So can you tell us more about sort of what your model is and how it differs from the traditional sort of pathway?
Definitely. So having the strength and conditioning background, playing football for so many years, and then after college, kind of chasing that. And I always had a passion in like fitness and strength training, and so I knew that that was going to be part of the model somehow. Just didn't know yet. And so through shadowing and going through school and then continuing ed courses, kind of like developed this model into like three separate stages, because I like the pain relief part, but that's just not enough for most people, right? And so my model is kind of three-step process. Let's get you out of pain, number one, first and foremost, right? So we do the muscle work, we do the adjustments if they're necessary, we do all the manual stuff in the room prior to that, after the assessment. And then the second stage from that is now the like rehab phase, new foundation phase. So once we have, we acquire new ranges of motion, now we can get into different positions for people. And so now on top of that, now after that's the strength training phase. And so on top of that newly acquired range of motion, we now start to add load and then keep on progressing from there. And for me, it just that model just makes a lot of sense. It goes really well with the strength training model. I get to have fun at the end of people's plan of care because I get to see them like PR, become the strongest version of themselves. And I think a big one here that people don't typically talk about and is very underestimated is the confidence and like the self-belief part. And so there's so many varieties and factors into pain. And so if we can address as many as we can and just check all those boxes, that's how people get results long term. You change their mindset, you change the way they view their pain, view their injury. They can see the light at the end of the tunnel. You start to show them things that they didn't think were possible. I think that's why we've been so successful, is because not a lot of offices, if any, are doing that, especially the strength training part. And so we kind of like bridge the gap from laying on the table to like PRing a squat or a deadlift. And
Mhm.
I don't think, a lot of places are offering that.
Yeah, and kudos to you for sort of breaking the mold there. I like those sort of that three-step process that you have there. And one of the things that sort of comes into maybe the perception of contrast between where we started and what you mentioned there is the fact that you do still utilize these sorts of adjustment, manual therapy, pain relief strategies. So when you are dealing with a client who maybe has an understanding, very, very, broad level of understanding around like what Cairo is, do you go through any sort of education process with the client? I obviously know that's a generalized sort of a question, but do you find that, a lot of people are very intrigued by the Cairo stuff? And so maybe you sort of spend a little bit more time on that, or do you usually find that you're able to sort of get through that initial phase within the first 10 to 15 minutes, and then you sort of designate maybe the majority of the session to the other stuff? How does that split kind of work for you?
That's a beautiful question, and very important because yeah, the education part here is super helpful for patients because typically we're a last resort type of office. They're at wit's end. They've been around the block. They've been to PT. They've been to Cairo, and they haven't gotten results. And so, unlearning the bad things they learned at the other office is a huge part of the practice because they've been told to constantly, let's just say, flex your core at all times to prevent your back pain, and that in turn could be leading to a separate issue, right? Or something like keeping a neutral spine 24/7 or posture, right? So staying on top of research has helped me like kind of make it very easy for the person to understand and like make it digestible so that they're not fearing those things 24/7. And then also having empathy for the people because everyone that comes in here typically wants to feel better, right? And so muscle work, adjustments, cupping, all that stuff makes them feel good. But I always explain it like this. Those are the fun stuff is temporary, right? The work that we're going to put in, the hard work, the grit, all the like tough positions you're going to be in, the strength training, that's going to be the longer lasting things that like matter more and I carry more weight with.
Mhm. Yeah, that's great. I like that reframe too. And that's probably one of the hardest parts of the process, I would assume, for you is kind of unraveling a lot of the biases and assumptions and indoctrinations that people kind of come into the office with, right?
Definitely. And unfortunately at other offices too, it's like I'm very careful with my language here because other offices are not. And so it's
Mhm.
very easy to say, yeah, you're tight here, you got the muscle knot right here, those kind of things that stick with patients, right? And so they think that there's like a problem with them.
Yeah.
So in here we're very, very specific with language and communication. And then also just not fear mongering essentially, right? Like in here it's all about positivity, what's possible, right? If you do have something going on, that's like we're never going to tell someone they're broken. And unfortunately, like I said, like this happens in other offices. So they come in, they straight up tell me they're broken or they don't know if they can be helped, things of that nature because other offices have told them that.
Mhm. Yeah, and that's a big word is like, excuse me, the idea that, we are fundamentally broken or that we have all these different kinds of things to fix. That is a place that I was in, as you know, for quite some time. And that's kind of what drove me in the direction of actually learning more. Because it's kind of sneaky, right? Like when we use phrases like we're tight or this is weak or I have bad posture and I need to have good posture or I have poor activation, all of those things aren't necessarily saying that I, as a human, am incompetent in all these ways. But that's what all those things are implying, right? It's like you should not be the way that you are, right? And as
Right.
long as someone is sort of chasing their tail in that way, it's very difficult to sort of get people to move in that direction. So one of the things that you mentioned there was just the word posture. I'm interested just from a concrete perspective. If I'm someone that comes into your office and I'm ignorant and I say, Jeremy, like, I've been to 10 doctors. I've been diagnosed with bad posture. I have awful posture. My shoulders are forward. My neck is forward, all these things. Um, how do you go about addressing that conversation with that person specifically in relation to posture, just to kind of pick one of those things? Where do you sort of start with those people? Do you start with questions? Do you start with more of a lecture based thing? Where do you sort of go with that?
Yeah. So the first question I typically ask is like, can you tell me more about that? Like just gain more clarity because it's very vague. Like, what is bad posture to you? What do you consider bad posture? What is good posture?
Hmm.
Just to get more clarity on what they think posture actually means to them.
Hmm.
And then from there, it's kind of dispelling some of the myth. And I do it in a very polite, kind way. I don't want to be brash and like, irrational. Um, but you acknowledge that that this is a concern of theirs. And then I give my perspective, like I said, in a harmless way. And just, this is what works for me. This is what I've done my homework in the research. And, typically it's not correlated to pain. And there is no standard posture. Like there's no gold standard posture. This doesn't exist.
Hmm.
And so I just tell people it's the way we manage gravity, and just getting in and out of position is probably your best option instead of just worrying about sitting upright, squeezing your shoulder blades, like, keeping your head all tall and all that. It's more so just getting in and out of positions, taking movement breaks if they're like a 9 to 5 person at a desk, and then just slowly educating them on that and how it's not so much correlated to pain and like damage as they think.
Mm. Now, do you find that the average patient that walks into your clinic is someone who we'll say is capable of understanding that relatively quickly? Or do you find that there's typically a lot of resistance to those ideas?
Ooh, that's a good one. So it depends. Some people are like, "Oh yeah, that makes total sense. Easy, done." Other people will continue to say it throughout the treatment program, and so it's just me constantly asking more questions, like, "Tell me more about that," and then just bringing it up again and talking it through. Especially with the
Hmm.
broken thing. Um, some people, I'll have that conversation with them, and then like 2 sessions later, they're like, yeah, just, my shoulders just, this is my bad side. And
Hmm.
so educating them on that, I'm like, wait, what side? Because you have two good sides. And
Hmm.
then we kind of laugh about it. I make it a joke so that they're not fully uncomfortable. But yeah, it's difficult with some people because they're so trained in thinking that way that like that's their like go-to, you know what I mean? And the self-deprecating humor, I don't tolerate it anymore. I just don't. I don't like it. I don't like it for myself. So I don't say it in front of clients, and I expect that out of them as well.
Yeah, that's great. I like that. I like that degree of nuance because that's something that is so built into people's language that oftentimes we don't really even recognize sort of the story that we repeatedly are telling ourselves about the way
Exactly.
that we think things are. We're just sort of blindly subscribe to certain things. Yeah, cool.
Same, especially with like CrossFitters, right? And I hate to pick on them, but like even things like, "Oh, this workout's going to be so bad." Like,
Mm,
what? Why are you saying that? Like, it's just the self-deprecating like humor, I guess. But it's like so ingrained in them that they like they're like masochistic, like they're looking for that. And
mm.
so those clients are typically harder to communicate with because of that.
So underlying all this stuff is obviously the complex topic of pain. And there's a lot of, conversation around pain, as you know, on social media. And more over time, with the sort of rise of what we'll call evidence-based practice, that sort of buzzword, scientifically based practice, you see people now talking about how pain, the biopsychosocial model of pain has so many influences. There's the emotional status, there's the relational status of the current state of a person's life, all the environmental influences to the color of the room and the fabric of the shirt, and right. And so very, very quickly, this conversation, as far as I've observed, gets very esoteric and very abstract. So when we're talking about pain, and specifically your framework around pain, again, I know this is 30,000 foot view sort of a thing. But what is your sort of pain model? Because obviously there are thousands of influences, probably, um, more than that, that go into the way that someone feels. But when someone comes into your office and they are dealing with pain, which is the reason that they come to you to begin with, how do you sort of address pain on like a principle based level? Do
Mhm.
you sort of cover the emotional, the physical, all maybe in the first session, or what is your sort of general approach to pain and getting people to conceptualize pain in a helpful way rather than a confusing or a harmful way?
That's a beautiful question too. So again, it'll be a wide variety because of the people that come in and their background and their perception of it. Um, but typically, if someone asks me like, "Can you guarantee me 100% pain free?" like at the end, and I always say no because there's just so many factors, like you mentioned. But what we do guarantee is that you're going to move better, you're going to be stronger, and you're going to have the education that you need to self-manage in the end, right? And so that's the tough part, is that pain is such a wild card, and it's honestly it's pretty stressful, because like you don't know 100% if that person will get better, and they're paying you for that. But what I do is I have my whiteboard on the right here. I have my big whiteboard where I can show them their ranges of motion and how those improve, their strength numbers, their PRs, right? Form, technique, all the stuff that I can control. I guarantee that, because I know
Mm,
that they'll be better here rather than a different office. But in terms of pain relief and like their view on it, I always say like, so the scale 1 to 10 is pretty useless, right? Everyone's got a different scale. But for that specific person, right, if we're like poking into the painful spot, I'm like, all right, tell me if this is like a 3 to 4, because you know what? That's okay. I'm okay with that. It's like you're dipping your toe into a hot tub.
mm,
Like, ooh, that's a little hot. So let's like slowly ease into this. Just that graded exposure style has been super helpful for people, because they understand like, okay, a little bit of pain is okay, right? Like we can tap into this a little bit, and then by like rep 4 or 5, they're like, wow, that's better, right? Like, oh, it doesn't hurt as much, something like that. That's been a game changer for me. And then in terms of like myself feeling like comfortable and safe doing that with somebody.
mm,
But yeah, it's a very slippery slope, because and you have to be able to hot route, I call it, now that I'm training my new intern.
mm.
He's very impressed with the way that I hot route. And so if something is just like not working out, I can hot route right away to a different thing, because of my strength training principles, my biomechanic principles, and things of that nature. So if there's a movement that's just not working for that person, you got to be able to hot route and put them in a different position to still achieve the same outcome, but in a different way.
Mhm. Yeah, yeah, makes sense. And so this concept of hot routing is basically sort of the willingness not to overcommit to a single direction, but rather to following that sort of first principles, or that sort of first principle approach of looking to improve general movement and not necessarily to improve single positions, giving a person the willingness to understand, or giving a person the education to understand that there are multiple ways to sort of crumble the cookie, right?
Exactly.
Yeah. Yeah. And that's something that I find in particular, you mentioned CrossFit. Sports like CrossFit and powerlifting are oftentimes the toughest to deal with in my experience. And obviously I'm not a clinician, but I've worked with many people who have had these sort of, general lifting pain problems. And so much of the time, at least, and I'd like you to speak on this, it seems to be a matter of people's refusal to do activities that don't hurt. You know what I mean? Like it sounds kind of silly, but
Yeah.
someone is very emotionally tied to doing pull-ups, but they haven't been able to do a pull-up in a year without a shoulder clunk, or doing barbell squats without feeling a low back thing. Do you typically, in those instances where you find someone is emotionally tied to these movements, do you sort of give them enough of that thing if they're experiencing pain with it, or do you look to at first sort of avoid those types of painful movements, or do you, obviously, again, it depends, but do you
Right.
typically find yourself avoiding, we'll say, those pain triggers in the
Mhm.
initial stages, or do you sort of give people a little bit of what they want and try to introduce it in a way that maybe is less offensive?
Yeah, so I'll give you a quick story about a patient specifically I'm thinking of. This was a perfect example. Usually we start to do the barbell movements towards the end of the plan of care. But for this specific person competing in CrossFit, just wanted to get to it right away, right? And so I tried a Zercher med ball hinge, and they were like, I'm never going to do this. And so again, I had to just kind of adapt to the situation. And so we went straight to barbell deadlifts. And so it functioned as like an assessment, which was great. I got to see their technique, got to see at what point it hurt. And so we made adjustments on the fly just like that. And so some people will just do that. We'll make adjustments like that. Or dynamic systems theory is kind of like, what is their attractor state? Like, what is their nervous system's normal? And then tricking the nervous system really quick. So like supersetting with something that's going to activate, let's just say, the front side of their rib cage instead of the back. Um, let's do a quick hard exercise to kind of trick your brain, and then revisit the same exercise right away. And sometimes like just doing that you can see quick results like that. Now, is that the long-term fix? No, but you're just showing that person like what's possible, and that it doesn't have to be painful.
Mhm. Yeah, and that also kind of teaches someone, I guess, that, to your point earlier about people not sort of living their diagnoses or their x-rays or their MRIs, that although they may present with something that appears to be structurally abnormal or problematic, that they can actually do these things without pain. That seems like it would be super empowering. Can you talk a little bit more about that whole story of people sort of living their diagnosis from the perspective of x-rays and MRIs? How consistently do you see people who have quote unquote good x-rays that do have pain versus quote unquote bad x-rays that do have pain?
Right. Yeah. So another good story is I posted this, I think during COVID. I got an X-ray just for fun of my cervical spine, and it looks really bad. It's, classic military neck, straight, a lot of degeneration. I played football for 14 years, so what's the shocker there? But I wanted to post it because I was the strongest I ever was, zero pain, and that was my message. It was like, your X-ray that definitely does not define you. Bad X-rays can be pain-free, and really good X-rays with like a 1 millimeter bulge can be like 10 out of 10 pain. And so the radiographs and the MRIs, they don't always like necessarily mean there's damage or mean that there's pain. It's not going to find. It's just a snapshot in time, and that's what I tell patients. Like, if you want to get an MRI, fine. I've sent 4 people out in 5.5 years for MRIs,
Mm.
and luckily, like, those were warranted, right? Like, one of them was a fracture, and one of them needed disc surgery. That was the one surgical patient that I've had in 5.5 years, and so just educating them on that and like kind of explaining my perspective from it. And thankfully now I have a good name in the community where people trust me. And so they take that instead of the other advice they've taken. And that's also, I think, why we've had so much success here, is because we're changing their mindset and like their perspective on it. And it's like, wow, this doesn't have to be a forever thing. I can actually go and play with my kids and bend over again. I don't have to fear lumbar flexion. I don't have to fear like my shoulder popping out, because this is possible, and I can get better, and things do heal.
So you mentioned that there were a couple times that in the last 5 or 6 years that you have actually opted for someone to get screening. Um, I'm assuming that based on that, it's not a common thing that you do. So what are the sort of variables or requirements that sort of lead to you making that decision?
Great point. So if people aren't getting better within like 3 to 4 sessions, right, like zero improvement, then I start to think about that. If it's not making sense to me, like the fracture, um, then I start to refer people out for that. But clinically, it has to make sense for me to refer. Like, and it really has to like raise a red flag in my head, right? And because thankfully, most of the people that I see are like, it's not a crate. It's like people that are actually active, and so I haven't seen too many crazy things like, a heart attack or jaundice. I don't see too much of those more, intense diagnosis. So I don't have to refer out often. But if things start to not make sense, or they're not getting any better, then I'll think about referring out.
Hmm. So it's very rare, if ever, that sort of right off the bat you would be asking for any kind of screening.
Yeah.
Okay.
Like I said, I think of a handful in 5.5, 6 years.
Yeah, and I think that's probably surprises a lot of people because
Yeah.
that's usually the direction that people go, and that's usually what I think leads people into PT or some kind of PT practice. Out of the gate is I have this diagnosed quote unquote issue, and I need to go to a PT to solve it. So I think a lot of people would be surprised about the whole conversation around the discrepancy between pain and what we think is a visual dysfunction or something that's visually abnormal.
Right. What I tell
Because
people is that if you want to get it for peace of mind, all that's perfectly fine. However, our assessment process is very in depth, and so my treatment's not going to change based on that picture. My treatment's going to be based off the assessment process, and
mm,
so I don't need that picture. I'll look at it, I'll see it. Oh, fine, that confirms like a disc bulge at L4, L5. Beautiful. I was already thinking that.
mhm. Yeah, so before, because I want to dive into what sort of comprises your assessment process and what that really looks like. Um, I have a couple of questions here that actually came from my community, where this one person was basically asking, from a specific sort of deeper anatomical level. We talked about basic chiro adjustments, right? You put people on a table, you twist them up, you wring them out like a towel or something similar. Um, could you speak to just a little bit of the basics around what, in terms of, the deeper biomechanical principles, is happening when we do those kinds of techniques? Like from a spinal standpoint, what creates a pop, what creates a sensation of relief? Can you speak to just the specifics of the anatomical sort of portion of that? Because that's something that I'm curious about, is sort of what's theoretically going on when we hear all those kinds of pops and when we get those kinds of relief.
Mhm. Good question. And a common one. I like to think of it as like a neurophysiological effect. So you are sending a signal up to the brain, right? The spinal cord is attached to the brain. And so we're getting that quick, it's almost like an endorphin release, right? And that's why it feels good. We're getting that signal up to the brain, like this feels good. This is pain relief, right? Getting those chemicals to be released. And the popping, in my opinion, is a gas bubble, like a gas release. So not the bone being put back into place, as most traditional chiros would tell you. I just think it's one of those phenomenons where it tricks your brain temporarily, and that's kind of like the attractor state I was saying, right? If we can do an adjustment, and for that 30 minutes that person feels good, and now we're loading them up on like a barbell back squat, and they feel good. To me, that's where the adjustment is where it fits in my model.
Hmm.
But to tell someone that I'm pushing it back into place and now you're aligned better and now your legs are perfectly aligned, and before it was uneven and now the adjustment made it even. I don't even I don't even go that route. I don't like to communicate that. I don't want to put that in people's heads. And yeah, so that's my answer for that.
So for the average person, would it make sense on a broad level to conceptualize chiropractic adjustments in a somewhat similar way to other kinds of manual therapy, like massage guns, foam rolling? Would you kind of lump it into that category, or is it something special?
100%. No, I think I would lump it into that category, similar to like a foam roller too, right? Like if you're foam rolling the outer quad and the IT band area, you're creating that neurophysiological effect where your brain is interpreting this information, and you're getting that sense of like release, right? And so now we get the chemicals released, we feel good temporarily, and that's why foam rolling. I used to shit on that all the time too, but it has those same type of benefits. And
Hmm.
so kind of just tricking your body into being like, oh wow, like I have this new sensation, this new range of motion, and now it feels pretty good for right now. But long term, right, and that's why chiros get a bad rap. Like that sensation and that feeling ends pretty quickly.
Hmm. Yeah, it's kind of like some sort of drug addiction almost, right? Where you need
Exactly.
to keep coming back. Yeah,
Yeah.
so I would then conceptualize, the cracking, popping stuff as something that can potentially take someone from, -1 to 0 rather than 0 to 1 or 2 or 3.
Right.
Right. Yeah. And the sort of things now that sort of potentially can take someone from 0 into the positive integers are going to be those assessments, the range of motion, techniques, training muscles and getting stronger. So let's talk a little bit more about that. You mentioned this word assessment and your
Mhm.
assessment process. After you sort of work someone, from -2, -1 to 0, where do you kind of start? Obviously, issue dependent, but from a broad perspective, where do you start with your assessment process, and what sorts of things are you looking for in your assessment process?
Good question. So thankfully to you, thanks to you, I went down to the PRI rabbit hole.
Mhm.
And what I did like about that group is their assessment process, specifically Bill Hartman's chessboard. And so I use that still today. It just gives me a better idea as where I do need to start. And so if I see a lack of rotation at a specific area, I'm going to start there. And then it just gives me a good framework as where we need to go. And then I get to show them on the whiteboard the improvements, which is also cool. So we'll always test in the beginning. We'll go through hip flexion, hip internal, hip external, shoulder flexion, internal, external, straight leg raise. We'll do squat, we'll do toe touch, and then we'll do the orthopedic testing that we have to do based on that specific injury. So if it's low back, shoulder, mid back, neck, we'll do specifics for that. We'll do neurological testing, we'll do muscle testing, just to make sure that we're putting all the pieces together, and that way we can implement accordingly and specifically.
Gotcha. So it's kind of like the assessment is meant to create a map, and then what you do or where you go using that map depends on sort of what you're getting back from a feedback perspective from that person.
Exactly. It just gives me a great starting point, and then based on whatever their goal is too, that's also very important. So I can reverse engineer, kind of plan what the outcome is intended to be, and then reverse engineer from there, see where we have to go through each phase, and then it helps me plan out accordingly. So we're not just giving them the same exercises. They're progressing every week, right? They're doing the homework. All of that has to be on the same page.
Now, something I'm interested in because I talk and teach mostly trainers and gym bros or broettes who are deep into the trenches of just lifting specific stuff. And a lot of the issues that I solve are purely exercise related. They're not chronic pain issues, not severe pain issues, just like, hey, I'm doing this pull down. It feels weird. How can I adjust it? That's kind of what my domain is, as you know. Um, and so something I'm curious about from a patient perspective, you mentioned all these different sorts of range of motion assessments.
Mhm.
Is do you often find that patients at a certain point will maybe start to become a little bit too attached to certain metrics? And if so, what is your process for sort of navigating that and educating your clients about sort of the nuances and the trade-offs of overly worrying about, do I have 15 degrees on this side and 10 on this side? Is that a problem? Right. Because it's somewhat, to some degree, it can fit into the posture conversation where I could see it being the case where, much in the same way that someone believes that the slumped shoulders are their problem, they might start to believe that a small discrepancy between range of motion between sides is a problem. So how do you, kind of view that in your overall framework, and how do you go about navigating that in real time?
Yeah, that's a good point too. I initially, that's why I kind of stayed away from this model in the beginning because I thought that exact same thing. Some people are going to be too attached, and that has happened a couple times, where they're like, "What am I at?" Like before we even get started, they're very intrigued to see their starting point coming in because they've done the homework, or they felt like they did enough to like improve all those numbers. So that is a tough conversation because it's not going to be perfect every time, right? Morphology is a big one, body type, just all of that. It's the education piece again. So listen, I know this seems like we're not making too much progress with the hip internal rotation, but we also, we're getting there, right? Like, give it time. We're working on it. Just kind of navigating that in terms of like their attachment to it. It could get pretty hairy sometimes, but again, it's happened, a handful. But like, yeah, people become obsessed, and then I'm kind of like digging myself back out. So with those type of people, I'll stop kind of showing them the numbers. I'll do it by myself. I'll do it on the notes. Um, but we'll just focus more on like the exercises and the outcome there instead of like just the numbers.
hmm And I'm sure you've seen instances, and correct me if I'm wrong, wherein someone might not actually make what we perceive as progress in the range of motion domain, but their pain can improve. Are those things that you see, or do you mostly see that range of motion improvement is correlated with reduction in pain?
Yeah, so for most people, the improvement in range of motion definitely helps. But for like elite level people, like bodybuilders, CrossFitters, people that are competing and they have a lot more like mass and tissue, those are harder to improve because they're so big. There's so much tissue there, right? And they're still going to continue on doing their sport, which is kind of the opposite of the mobility thing.
Hmm.
So those people are, having that conversation, like, all right, this is just your baseline. Like, if we can get a little bit of improvement, like that's awesome. But we'll probably go based off of your pain and your performance in there rather than the range of motion numbers.
Hmm. Yeah, it makes sense. So the last kind of thread that I want to touch on here is that final sort of stage of Jeremy's three stages, which is the sort of training aspect and the strength improvement, the muscularity improvement, taking someone from the table, reducing pain, improving range, improving the tests that you do into the weight room can be a tricky thing because a lot of people, in my experience, who are in pain are often not training to begin with. Or if they are, they're doing a god awful job of it. So, of course, it depends on sort of where someone is coming from, but let's just take the average client who's maybe not that elite CrossFitter, elite bodybuilder. or elite hybrid athlete of sorts. Where do you sort of generally start in terms of strength? Do you have particular metrics that you follow? Do you have certain guidelines that you follow? Where does your sort of head go when you're looking at like creating a framework for someone and improving their strength in the gym?
I'll try to meet people where they're at physically, because those fitness levels, like some people you'll be surprised that, like, holding a 5 second, isometric is tough. And you're like, wow, I thought that was going to be at least like 30 seconds, right? So you meet them where they're at, or like vice versa with a barbell on their back. Like you thought that like doing a tempo would be, achievable for 5 reps, and like after two, they're like burnt out. So that is tough, and I think that's part of the art. The artist part of it is like adapting to their fitness level, and then tracking that, and then making sure that we're pushing it in different ways too. So tempo, volume, ISO holds, um, weight on the bar, range of motion, right? Like block pulls, box squats, making sure that first and foremost that it looks good. Technique, right? Having the coach's eye is very beneficial for me, because I can see where they're kind of compensating, or maybe one foot is shifted a little bit farther than the other, and making their awareness, bringing like awareness to that. So that has got to be in place first, and then kind of adding the variables like I just mentioned, tempo, range of motion, all that. And then being aggressive. I think like people want to be pushed and led. And so that's why personal trainers have that's such a great job, is because people just, they want to show up and be taught and told what to do.
Mm.
And so I'm aggressive on that front, because I know they're not going to get it anywhere else. They're not going to do it at home, most likely. And so in here, I'm like, in a safe way, I'm going to push them as hard as I can in here. And so most people leave sweating, hot, tired from a workout. That's the goal. And because I want to push them in here, so then they know that this is not some traditional PT place where you're getting the pink bands and the pink dumbbell. Like you're gonna be sweating, like you're gonna be uncomfortable mentally, and that's good. And pushing them physically and mentally, I think, again, is another bonus of being here, because a lot of places are scared to do that, and they're afraid to push it into pain. And I've already made that decision. I am committed to being the aggressive doctor.
Yeah, new title, new
Yeah.
new Instagram handle. Um, yeah, that's a super interesting concept, right? Because what you've just described is like basic strength training, right? Is like
Mhm.
picking basic movements, loading them, getting better at them over time. And weirdly enough, this does not seem like something that many PTs are particularly comfortable doing,
Right.
which of course it depends on population. Someone who is bedridden for 6 weeks after surgery or whatever the hell is going to see hypertrophy from trying to stand up out of the bed, right? But that's based on what I know about you and the population you serve. That's not really you. So I would love to see PTs stepping a little bit more into the bucket that you are currently in, perhaps not as aggressively if they're not as skilled, but more so certainly than they are now. So
Right.
do you find that many people, when they sort of take that leap from the range of motion, more sort of rehabby-esque movements into the strength training realm, do you think a lot of people have sort of fear around that?
Definitely. Um, and I feel like that's where I thrive, is because of my attitude, and my confidence in them. I always say, like, you could just borrow some of my confidence, because I have the confidence in you 100%.
Mm.
And so when they're fearful of that, I'm like, it's got to be a good coach at that point. So that's why I say, like, I'm a Chiro, PT, coach, whatever you want to call me. I don't care. I'm just here to push you to get better. And so having people go in there after doing, let's just say, like a lower level breathing exercise, and then to, like, something that's weighted, there is some hesitancy sometimes, but I'm there to help. I'm there to support. I'm there to make them feel safe. I'm not going to push someone to do something they don't want to do. I'm going to just push it hard in something that they're confident in, and that I know is going to be okay.
Yeah. So wrapping this all up and sort of tying a thread here to kind of integrate a lot of the stuff we talked about. One of our community members was also talking about the difference between sort of chronic pain and acute pain, right? Because a lot of the situations you've described are like someone maybe comes in with a quote bad shoulder, right? And you sort of help them with that and maybe acutely you see results within a session, within 2 sessions, 3 sessions, or whatnot. What advice can you give people who are maybe in a place where they're dealing with chronic pain, but
Mhm.
are not in a position where they are doing poorly enough to seek professional help, right? Because some people are in that sort of zone where they
Mhm.
wake up and it's the same left SI joint. It's the same problem every time they lift, but it's manageable. They can kind of work through it. I'm looking from you for some bits of advice for that person in just managing their own sort of chronic pain. Obviously, N of one, you need to do it on a patient to patient basis. But for those of us who are maybe struggling with lower level chronic issues, what are some principal takeaways that people can have from your framework and from your experience to help them sort of get educated and navigate those circumstances?
Mhm. I would say kind of how I treat the people in here. It's like, let's find a exercise that feels good. So we reintroduce that positive experience with movement. And then more specifically to that, like maybe it's a bilateral thing that hurts. Let's try the single leg version. Let's try a different variation of that that does feel good, so that you can continue to train and not experience that pain. Same thing with the shoulder, right? If it's like a barbell bench press, maybe we should try some single arm, dumbbell presses, or single arm cable, or alternating cable, some stuff like that. You can still push it, and ideally that's less painful and a better experience. And so it's temporary, right? You don't have to do that forever, but for the time being, let that thing settle down, whatever it is, and then do a different variation. And as that heals, revisit the other one, and then slowly start gradually building that one back up again. That would be my best advice in terms of not seeing a professional. And then again, like doing stuff that feels good, like walking. Walking is a very basic free exercise you can do. Get the steps in. Again, like music. I mean, some people just like stuff like that that makes you feel good. Um, Music, people will go months without listening, and I'm like, you got to enjoy yourself. Like, go for a walk, listen to your favorite song. Like, that's again, pain is very multifactorial. So doing things like that, stepping out of your comfort zone, doing like if you're not a hiker, maybe go for a hike. If you're not a surfer, maybe try surfing. Things like that to still promote exercise and movement, but not necessarily the painful one. And then revisit that, of course, when you start to feel better or when you think that it's calmed down.
Yeah, so kind of tying in the thread there of not necessarily being tied to any one thing, number one, and then number two, being willing to explore, we'll say, educated distractions in
Yep,
the realm of physical fitness and training. So,
exactly.
are there any other things, Jeremy, in relation to Cairo, PT, the whole works that you feel like maybe we didn't touch on that you would like to just briefly sort of mention or touch on in this conversation?
Yes, I thought about it because I forgot something earlier and I just remembered it. It's the differentiation between pain and muscles working. So, a easy example of this is the deadlift, right? Is my back working or is that back pain? Is
Hmm.
a very, very common question. And it's a very common topic that I address here because people will say, I feel that in my back. And I ask them, like, can you be more specific? What does it feel like? Oh, it feels like, something's happening, something's working. And I'm like, is that sharp, painful, dull, burning, achy? No. All right, beautiful. That's not pain, and that's completely normal because your back is working on this exercise.
Mm,
And they're like, oh, it's not like messing me up even further. I'm like, that feeling is supposed to be there.
mm,
So differentiating pain versus muscles working and like fatigue, like a bicep curl, right? If you do 20 reps of 20 pounds, like that's gonna freaking burn at the end. That's not necessarily mean your bicep's gonna tear off or you have a labrum injury. You know what I'm saying?
mm.
And so differentiating those two for people, you'd be surprised at how commonly I have that conversation, is a big one because they're unsure of that feeling. They think it's bad. But so opening up their perspective and their eyes to saying like, no, that's totally okay. That's actually normal because the muscles are doing their thing.
Yeah, 100%. And it's fortunate and unfortunate because that requires some threshold level of education around, what is an exercise doing and what is an
Right.
exercise not doing, and how are similar looking exercises different, right? Because if you feel your back during a deadlift, well, I'd say that's probably normal, right? But you may also feel your glutes, right? But you may
Right.
also do a different exercise in which you feel your glutes, but you don't feel your back, or you do
Right.
feel your back, but you don't feel your glutes, and how to manage that is definitely not something to address on a generalized level, but rather a sort of case specific level.
That's why they
Uh,
should sign up for your group.
oh, and he finishes with the self plug, or the Benjamin plug here. Um, Jeremy, this was great. Where can the listeners go to find you? Where are you located? Not
Right.
physically,
Oh,
but
well,
online, because they'll find you
online.
physically if it's online first.
Instagram is probably the most active I'm on, and that's RSM underscore athlete underscore doc. And then emails Dr. Jeremy at rsmsportsmed.com.
Beautiful. And should people message you in vague terms asking about how to fix their back pain or not?
Yeah, I love that, especially when they're from India and they're just like, fix my sciatica. That's my favorite.
All
They're
right,
telling me
beautiful.
what to do.
Yeah, beautiful. All right, Jared, thanks for coming on. I'd love to do this
Thank
again
you.
sometime.
Hell yeah. Thanks for having me.